am now going to turn it over to Dr. Liat Gutin, who's going to introduce our second speaker.
Okay. Hi, everybody, and thank you so much, Dr. Johnson, for that great talk. Just a quick reminder before we move on to our next speaker. Wanted to thank our sponsors again quickly for sponsoring this symposium. We have Genentech, Intercept, Gilead, Pfizer, Echosens, Dynavax, and Janssen. And just another reminder for everyone who's logging in a little bit late, we have an app that if you all can kind of log in and engage with, there are several gift cards available, $100 and $200 gift cards. And it would be great if we can kind of all interact on that app. So check it out if you haven't had a chance yet. And with that said, I'm excited to introduce our next speaker, Dr. Neil Mehta. Dr. Mehta graduated from UCSF Medical School before completing his internal medicine residency at the University of Pennsylvania. He then returned to UCSF for both his GI and advanced hepatology fellowships and subsequently joined as faculty in the Department of Gastroenterology and Hepatology at UCSF in 2013, where he now serves as an associate professor of clinical medicine. He has a particular expertise in the management of hepatocellular carcinoma, and along with Dr. Francis Yao, manages the majority of patients with liver cancer at UCSF. He's also published extensively on HCC and has been first author on several major papers that have significantly impacted the management of HCC patients and organ allocation for liver transplant and HCC. Dr. Mehta is also a fantastic clinical educator and a committed mentor, which I can attest to from personal experience. We're really fortunate to have him speak to us tonight on the topic of management of HCC. So with that said, I'll hand it over to Dr. Mehta. Thank you so much for your talk tonight.
All right, thanks so much, Liat. It's great to be here, and I love the turnout and excited to talk, and also hopefully kind of have a nice Q&A session as well. So this is a nice segue. We just heard from Dr. Johnson about advanced HCC and all the great options that are now available. I wanted to kind of talk about earlier stage or earlier intermediate stage hepatocellular carcinoma, including with a focus on liver transplantation. So in these 20 to 25 minutes, I was hoping we could briefly talk about HCC diagnosis and staging, but really talk more about things like selection criteria for transplant and how to improve them, different local regional therapy options, some of the outcomes for patients who initially exceed Milan or conventional transplant criteria. We call them either downstaging or Allcomers criteria. And then if we have time, we can briefly, or if the audience is interested, we can briefly talk about kind of post-transplant management for recurrence surveillance. So this is a case presentation of a 55-year-old gentleman with alcohol-associated cirrhosis who's found on screening ultrasound to have a 3-centimeter lesion and in the quad phase CT scan that is done confirms the presence of a 3.5-centimeter lesion in the right lobe. On exam, the patient doesn't have any spatter nevi, but the spleen tip is palpable. You can see their labs here, including a bilirubin of 1.7, a slightly elevated INR of 1.3, a platelet count of 85,000, and an AFP of 36. So these are, when we were seeing these patients, what we ask ourselves is, first, what are the typical characteristics of HCC on a quad phase CT scan? And then we always wonder, is this, patients often obviously also wonder, should we biopsy this lesion and why? So, normally we might open this up to the group, and certainly anyone's more than welcome to unmute themselves and kind of chime in. Okay, but in general, over the last 7 years, we've really tried to be following the LIRADS criteria that you may have heard about. They have major and minor diagnostic criteria, and they really standardized our radiologic approach to the diagnosis of HCC. So these are the major criteria. There are tons of minor criteria we're not going to get into, but in general, HCCs are fed by the hepatic artery, whereas most of the liver is fed by the portal vein. And so we get this differential blood supply that we can take advantage of when we're looking at HCC. And so because it's fed by the hepatic artery, you get arterial phase hyperenhancement. And then when the rest of the liver is getting its portal venous blood supply and the cancer is no longer, then it washes out. So that's the delayed phase washout you'll see on the venous phase or the delayed phase. These lesions also can have a pseudocapsule, and also if the lesions are growing, they're more likely to be HCC. And the most important thing I think about LIRADS is that the bigger the lesion, the more likely it is to be a liver cancer. we typically use 2 centimeters as a cutoff that distinguishes between T1 and T2 HCC. But the bigger the lesion, the more likely it is to be an HCC. So here's a couple examples. You can see this in the arterial phase. Aorta is bright, cancer is bright. Later on, aorta is no longer bright. We're on a portal venous phase and delayed phase. Now we have our washout. And then you can also, on the delayed phases, often see a pseudocapsule or a capsule. All of these features are LIRAD's major criteria. And so radiologists, anytime they see a patient at risk for HCC, they should, with a liver lesion, they should be assigning it a LIRAD's designation. This is important to realize that if a patient doesn't have a risk for cirrhosis, then they should not be giving them a LIRAD's designation. So really, this is confined to patients with risk factors for liver disease and cirrhosis. So obviously, this is not something you need to memorize, but I do want you to be aware that the radiologist should be going through these different categories: washout, capsule, growth, size of the lesion, hyperenhancement, to come up with a LIRAD's designation. Now, there's two main reasons I go into this in a little bit more detail. The first is to show you that LIRAD's is actually quite accurate. In terms of when we call something a LIRAD's 5 lesion, that's what we're calling definite HCC. It's not definite, but 95% of the time it's an HCC, and 98% of the time it's a malignant lesion. Often those other 3% of the time may be a mixed HCC cholangio or a cholangio, but in general, LIRAD's 5 is an HCC. About 3/4 of the time, a LIRAD's 4 lesion is an HCC, and about 37% of the time, LIRAD's 3 lesions are HCCs. The other thing I wanted to point out about the accuracy of LIRADs is there is a LIRAD's M designation standing for malignant, but not necessarily HCC. And so in these cases, about 37% of the time, these lesions are biopsied and end up being HCCs, but 19 out of 20 times, 95% of the time, they are malignant. So these are the lesions that we typically biopsy. We almost never biopsy LIRAD's 5 lesions, unless we're really thinking about something like systemic therapy, like we were just hearing about. Often those patients do get biopsied. And then LIRAD's 3 lesions we typically will follow. And then LIRAD's 4s really will depend. But in general, we do not biopsy these lesions because HCC is a radiologic diagnosis. Now, this is kind of a nice framework for how we think about HCC management. This is the BCLC staging classification. We just spent 30 minutes learning about the advanced stage, patients with portal vein invasion, nodal involvement, metastatic disease, and the newer agents that Dr. Johnson just told us all about. Now, we're going to be focusing the next 15 to 20 minutes on earlier stage HCCs. So these include patients with very early stage, as well as, so a single lesion up to 2 centimeters, for example, Child-Pugh A disease. These are patients we often think about resection on. As well as patients who have a little bit more tumor burden. Also, we think about resection as long as they don't have significant portal hypertension or multifocal disease. We'll come back to that here in a moment. And then we're going to spend the most of our time talking about transplantation, both for patients, these are in patients in their early stage, BCLC-A, or patients who are beyond Milan criteria, but we can downstage them into Milan criteria. So the same patient I mentioned earlier has their CT scan, and it actually confirms arterial enhancement with washout. And so we're going to call this a LIRAD's 5 lesion when we review the patient in tumor board. Again, same labs as before. Bilirubin is elevated at 1.7. Platelets are slightly low at 85,000. INR is 1.3. And we have to think about, okay, so this is a single lesion in the right lobe. Should we be resecting this patient? And if so, are we going to do this by in a segmental or anatomic approach, or instead will we wedge it out? Or should we consider liver transplantation or other therapies like ablation? And again, I'd love to hear any thoughts through the chat or unmuting yourself that you have. But when we think about a patient like this, the most important things that we first need to think about in terms of surgical candidacy, the gold standard, the first thing that you want to offer if you can is resection, right? We are going to go through why transplant is a better oncologic approach, but we have a limited amount of organs. And so if a patient is resectable and might have a good outcome with resection, that should be our treatment of choice for early to intermediate stage HCC. On the other hand, in this patient, we have to think about, in all patients, we have to think about how much portal hypertension do they have? Because if they have portal hypertension with their whole liver, you can imagine if you cut out some of them, their bilirubin likely, part of that liver, their bilirubin will likely rise, and they may have exacerbation of their underlying portal hypertension and get variceal bleeds or worsening ascites, et cetera, and have decompensation. So in this case, this patient appears to have clinically significant portal hypertension based on their ascites, spleen to palpable, low platelet count. And so this is likely not a patient we would consider resection for. And instead, we think that transplant would be a good option. So this is just some of the data showing why that is. So this is from a long time ago, but it was a very nice study that showed that patients who undergo resection who either have portal hypertension and an increased bilirubin really do not have a good 3 or 5 year survival. On the other hand, if they have a normal bilirubin and no portal hypertension, then they can do quite well with resection. So to summarize our approach to resection, kind of a minor point of this talk, is that the ideal candidate is someone who has excellent liver function, so either non-cirrhotic or Child's A cirrhosis, someone who has no portal hypertension. So for example, either their spleen is normal size, their platelet count is greater than 100, for example, is the cutoff we typically use. We want their bilirubin to be normal. And in an ideal world, we know that the more tumor you have, the more likely you are to recur with resection. And so in an ideal world, you'd have a single lesion, no more than 5 centimeters. And we know that the more of the liver that you have to resect, the higher the chance of decompensation. And so in a patient who has a lesion in a segment 2 or 3, where you can just do a left lateral segmentectomy, that's an ideal location for a laparoscopic resection. All right, so what about transplants? So this is how I like to think about the approach to liver transplantation for HCC. And this is where I want to spend our 15 minutes that we have left. So we all have had these patients that are within Milan criteria. And in an ideal world, patients who are not resection candidates would go, straight down this line to liver transplant. And however, there are multiple kind of factors that can modify this approach. We like to think about things like, how are they responding to local regional therapy? Does that affect their likelihood of getting to transplant? What are their biomarkers, especially their alpha-fetoprotein and other, we're not gonna have time to go into other biomarkers that have gotten more press lately, like NLR or AFPL3 or DCP. Certainly happy to answer questions about that in the chat later. Or PET scan, what is the role of PET scan? So there are other features that can help us determine whether this patient will and won't get to transplant. And if they don't, if they have tumor progression or liver-related death, are they gonna have liver dropout, right? There's 2 reasons why a patient with HCC typically may drop off the waiting list. Either their cancer progresses beyond conventional transplant criteria or what we call the Milan criteria, or they may have worsening of their liver function and have a liver-related death. So 2 competing reasons why they may have waitlist dropout. But that's just part of the story. We also can take a patient beyond Milan and actually do tumor downstaging with a lot of the same kind of factors that we pay attention to. They have to have an excellent response to local regional therapy to be downstaged to within Milan, and then they can be listed. This is in the US and other countries where the Milan criteria is not the gold standard. Other countries are allowed to transplant patients beyond Milan criteria. And same thing, they can also have waitlist dropout. And then finally, if we do have time at the end, we can go through kind of what are the risk factors for HCC recurrence and how do we look for that. So in terms of the Milan criteria, a lot of you are already familiar with this, but this is patients with a single lesion up to 5 centimeters or 2 to 3 lesions, none of them greater than 3 centimeters. Since we're talking about transplant, we don't want patients to have any disease, any HCC outside of the liver or in the or have macroscopic vascular invasion, because those patients have a prohibitively high risk of tumor recurrence post-transplant. It's important to note that earlier I mentioned that with resection, patients, it's not a great oncologic approach, actually, unfortunately. So with transplant, we actually see 5-year survival rates of 75 to 80%, which is quite good. And with 5-year recurrence rates of only 10 to 15%. If you contrast that with resection, in general, 5-year recurrence after resection is closer to 60 to 70%. So speaking in oncologic treatments, transplant is a much, much better treatment than resection, because with resection, you're leaving the cirrhotic liver behind, and the cirrhotic liver is what allowed that cancer to grow in the first place. The other thing I want to point out about this slide is that it makes a distinction between stage T1, which is a single lesion up to 2 centimeters, and stage T2 criteria, which is the rest of the Milan criteria. So nowadays in the United States, a patient with T1 criteria no longer gets points. You have to have, if you only have 1 lesion, it has to be at least 2 centimeters before treatment before you can get points. And a quick note about recurrence: the HCC recurrence is the most common cause of death after transplant for And the median survival after HCC recurrence after post-transplant is, just around a year, a little over a year. So if you have recurrence after transplant, that's a bad outcome that we're trying to avoid. So we really need to focus on patient selection as a key to preventing recurrence. So what are the kind of updates in liver transplant in the US for HCC recently? Well, the first most important thing is since the LIRADs came out, we now mandate that only patients within T2 or /Milan criteria with LIRADs 5 lesions can get priority listing, or if it has to be biopsy proven HCC. Additionally, we now have a mandatory 6-month waiting period before awarding MELD exception. So you might wonder why that is. Well, for many years, many publications showed that patients with HCC had unfair access to transplant. They were getting transplanted at much higher rates than patients without HCC, which is not kind of in the spirit of how MELD exception would work. And so this was a very nice LSAM, or liver simulation modeling, done by Julie Heimbach and Rio Hirose, that showed that if you delay the MELD exception by 6 months, for example, or even 9 months, you can very nearly equalize access to transplant or rates of transplant between HCC and non-HCC patients. And so this was put into place a few years ago. And the other thing we've worked on over the years is that really we found that there's significant regional variation across the country in access to transplant for these patients. This is just one of the studies that's been put out that looked at different wait time regions and showed that patients' risk of waitlist dropout with HCC after 2 or 3 years really was entirely dependent on where they lived. So we're here in region 5, which is a long wait time region. Patients would have almost a 30% risk of dropout versus if you're here in regions 3, 10, and 11, then you'd have a much lower risk of waitlist dropout. That didn't seem fair because we were just making up the HCC points anyway. So if you're gonna make it up, you might as well make it fair so patients aren't flying from the Bay Area to New Orleans or Jacksonville. So that's what we've done. So this was recently put into place where now instead of giving patients more and more points with this MELD exception points for HCC, instead now we award a fixed median MELD score at transplant -3 points for the area where the candidate is listed. So for example, if you have a patient who's listed for transplant at any of the Bay Area centers, CPMC, Stanford, or UCSF, we have to wait 6 months from the date of listing. And then that patient will then get median MELD at transplant -3. So the 3 of our centers have a median MELD at transplant right now of 30. So we take 3 away and all of our patients, wherever we're listed, would get 27 points and remain there until transplants. On the other hand, if their patient is listed in New Orleans, they wait 6 months and then they might get 23 points, for example. And the goal is that you're trying to, hopefully patients will wait the same amount of time wherever they're listed until they're transplanted. All right, so that's the idea behind transplant and the Milan criteria. I did want to spend some time talking about transplant downstaging. So this is another case of a 56-year-old male with chronic hep B who is not getting adequate HCC surveillance and actually was found with 2 LIRADs 5 tumors measuring 5 and 3 centimeters. The patient is asymptomatic, good performance status, platelet count's 84,000, bilirubin's 0.9, hepatitis B DNA is negative on treatment. And so this is the patient's scan. You can see this 5 and 3 centimeter tumors. And so we have to think again about what treatments would we recommend. Is this someone we would send to GI oncology to Dr. Johnson and say, hey, should we do sorafenib or atezo-bev? Is this someone who we might consider resection, or is this someone that we might consider transplant? And in the interest of time, I'll just tell you that because the platelet has clinically significant portal hypertension and has multifocal disease, resection is not a great option. These lesions are way too big for ablation. And so while we were talking in the question and answer session earlier about whether we might, Dr. Holt is saying, maybe we might be moving earlier and earlier to referring this patient for atezo-bev, we still think that the best oncologic treatment is transplant. And so if we can get a patient a transplant like this, that's probably where we should start. So what is downstaging? It's a reduction in the size of tumor using local regional therapies to meet acceptable criteria for transplant. We base our tumor response based on only the size of viable tumors. I'm going to show you a picture of that. We don't include the size of what appears to be dead tumor. And we also really like downstaging because it's a selection tool for tumors that basically, if they're responding to downstaging treatments, we think they're more likely to do well after liver transplant. So this is a different patient, but a 6 centimeter tumor here at the dome. You do 1 treatment, for example, TACE or Y90, and now some of it looks alive, some of it looks dead. So we only measure this part and we say, okay, now they're within Milan, under 5 centimeters. we can list them for transplant, but let's go for complete necrosis. So we treat them again. So this is kind of how downstaging works. What are the different options for getting patients to, whether it's from downstaging or as a bridge to transplant? Well, it's a little bit outside the scope of this talk, but just to be aware of our different armamentariums, treatment options that we talk about during tumor board. Certainly TACE or transarterial chemoembolization and radioembolization, transarterial radioembolization or TARE or Y90 are kind of the backbone at most centers of treatments. These are done by interventional radiology through the femoral artery into the hepatic artery, targeting the tumor. But there's other options, including ablation. Nowadays, most centers are using microwave ablation, or there's also external radiation or stereotactic SBRT. So this is just an example of one such treatment of a TACE, where IR would go in with a catheter into the hepatic artery that's supplying the tumor. You can see actually here, it looks like there's two different feeding vessels, and they'd inject doxorubicin and other chemocytotoxic agents into the tumor. Y90, on the other hand, has very high radiographic response rates. I need to update this slide. We do know that there is a level 1 evidence for survival benefit of Y90 now. It really is nice for larger tumors. Patients usually won't tolerate it if their bilirubin's higher than 3, but up to that, Y90 is a really good option for larger tumors. This is the only well-done randomized controlled trial that compared TACE to Y90. This is the premier trial out of Northwestern, very small study, and showed much longer time to progression for Y90 than conventional TACE. However, survival was no different. So for now, we kind of recommend them similarly, though we may get more data soon about these two options and which one is preferable as upfront treatment. So when we think about downstaging, these are now national criteria. Patients that are with beyond Milan criteria, for example, if you have one lesion, you have to be, since you're beyond Milan, you're greater than 5 centimeters, but you're no bigger than 8 centimeters. And there's other criteria for if you have multifocal disease, still no vascular invasion. And we still do have a built-in observation period to make sure patients who get downstage into Milan stay within Milan before they proceed to rapid transplant, for example. So we have really good data now over the years that shows that patients who are downstaged do just as well after transplant as patients who are always within Milan. This is just from UCSF data. This is a multi-center effort that showed that 5 years after transplant, after downstaging, we saw excellent 80% 5-year survival with low rates of recurrence, even with long post-transplant follow-up. So we really do think downstaging is an excellent option for patients. And so this patient I mentioned would fit within downstaging criteria, and it would be appropriate to try to treat them with local regional therapy and try to downstage them. And it's important to note if this patient gets to within Milan criteria, nationally now we would automatically award them points or MELD exception, similar to what if they had always been within Milan criteria. So how does this work on a national level? I just really quickly want to mention that we have our Milan patients, our downstaging patients who are candidates for automatic exception if they're downstage, but then you can be beyond that. You can be an all-comer. And what you see in this slide here basically is that as you have more and more initial tumor, your post-transplant outcome gets worse and worse. We think that the UNOS downsstaging outcomes are actually not statistically different. And I've kind of shown you that single and multi-center data already. But these all-comers patients, the ones who have a lot of tumor up front, even if these are patients who do go into Milan criteria before transplant, but they do have a worse post-transplant survival. And so we have to be very careful with the all-comers patients. So Milan and UNOS downstage patients, once they're within Milan, always get MELD exception, but the all-comers are considered on a case-by-case basis. So if we go back to this patient, we decided to use Y90 therapy. This was done with a planning angiogram. We have to do a shunt study to make sure that we're not going to irradiate places that we don't want to irradiate. And then this is what the patient's scan looks like 1 month after the first Y90. You can start to see a lot of cell death here, a lot of tumor death here with some viable disease on the periphery. And then we decided to treat them again. And now you can see that after 2 treatments, almost all of it looks completely dead. So in addition to downstaging and thinking about patient selection, one of the other most important things we have to think about is the patient's alpha-feta protein, which is an excellent marker of tumor biology. This has been shown in multiple studies over the years that the higher your AFP going into transplant, the worse your post-transplant outcome. And so this first slide is data from a multi-center consortium in France showing that patients who have a very high AFP will have poor post-transplant outcomes. This is data from Bilal, who's on this call here at UCSF, that shows that if you have an AFP over 1,000 going into transplant, you do extremely poorly. So we take this kind of as fact, and we know this, and we've adjusted policy based on this. This is more data that shows this ill effect of a rising AFP at transplant, but also combines it with how much tumor burden you have. So this is called the Metro Ticket 2.0 calculator. And this is basically the concept that the more AFP, the higher your AFP or the more tumor you have, the worse price you pay, the worse you'll do after transplant. So centers or other countries have to decide what is their AFP threshold and their tumor burden threshold that they'll allow for transplant. So in the US, we say that if you're ever over 1,000, you can't go to transplant until your AFP falls to under 500 with local regional therapy. The last few minutes, I just want to say one quick thing about response to local regional therapy. So we talked earlier that downstaging by definition means that you're responding to the local regional therapy. There's been some really nice data that shows that. And so this is a Mayo study that shows that if you respond to TACE, you have a much lower recurrence rate after transplant than if you didn't respond to TACE. This is a multi-center study out of Europe showing a very similar thing where when we think about risk factors for worse outcome after transplant, we think about rising AFP slope and tumor progression, meaning that you have more, after your treatments, you have more lesions popping up or growth of lesions. And so if you have if you have neither of these risk factors, even if you're beyond Milan criteria, you do really well. But if you start to develop risk factors, then you can start to see that your post-transplant outcomes start to worsen. So I think we're low on time. So I might come back to this if people are interested, but I just want to summarize this talk by saying the Milan criteria remain the gold standard for selection criteria in the United States, even though they are relatively restrictive. Currently, after a 6-month delay, eligible HCC patients are now awarded median MELD at transplant -3 points rather than the previous ladder upgrade system. We do see similar post-transplant survival that's observed for Milan and downstaging patients. And so downstaging is now accepted as national policy. On the other hand, patients with initial tumor burden beyond the UNOS downstaging criteria, the so-called, what we've called Allcomers, have to be carefully selected on an individual basis. We have to pay attention to their response to local regional therapy, what their AFP is, things like that. We do know that AFP is an excellent marker of tumor biology. And as your AFP rises, your post-transplant outcome is going to get worse. And now in this country, if you have an AFP ever over 1,000, you're excluded from transplant unless it falls to under 500 with local regional therapy. And I think that's mostly what I wanted to say. Hopefully we have some questions that I could help with.
Yeah. Neil, thank you so much. That was a fantastic talk and a really great overview of management of HCC. We do have a couple of questions that I'll go through in the next couple of minutes, depending on how much time we have. But our first question is, what is the role of AFP L3 and DCP in HCC diagnosis and management?
Yeah, great. So L3 and DCP are other biomarkers, tumor biomarkers that have been used in Asia for many years, but they just haven't caught on here yet. If you do order a HCC biomarker panel, you will actually get an AFP, L3, and DCP. And at the beginning of this talk, I mentioned I have no disclosures. I should mention now that I have received funding from Fujifilm Waco, who's developed L3 and DCP. So just wanted to mention that. But within that context, I do really like these biomarkers, okay? So especially for, I think, certain prognostic purposes. In terms of diagnosis, AFP, L3, and DCP, along with AFP, have been used and can be used in combination to actually help with HCC diagnosis. So there is something called the GALAD score. GALAD is gender, age, L3, AFP, and DCP. And basically, it's a combination of these 5 factors. And it tells you how likely this patient is to have HCC. And one of the reasons why GALAD has become, because males are more common than females to get HCC, and the older you are. So that's why those gender and age are there. But GALAD's very interesting, especially during COVID, because even before COVID, only about a quarter of patients at risk for HCC were actually getting Q6-month ultrasounds. And so if we're not going to be adhering as a society to kind of guidelines for whatever reason, often it's access to ultrasounds, or patients forget, or the ultrasounds are, ordered 6 months ahead of time. And, but what if you can actually order a biomarker panel and then calculate their Gallup score. And if it's elevated, then you go straight to your CT or MRI. So that is one thing that's been proposed. And during COVID, when maybe patients don't want to go out to an ultrasound or can't engage for a lot of different reasons with at the radiology center and get an ultrasound and want to be exposed, for example. So Gallup is an interesting concept that has gone through phase 2 and now phase 3 testing. And so I think there's more to come, but that may end up being the future rather than Q6-month ultrasounds. Now, in terms of what about in management, well, that's a little bit trickier. We do have some preliminary data at UCSF that AFP-L3 and DCP at the time of transplant really do predict high-risk explant and likely are going to end up predicting post-transplant outcomes just like AFP does. This is very preliminary, but that's the expectation. So we're using it more and more in different in fields. So more to come for sure. In general, we tend to think of cutoffs, is important to mention here. I like to think of L3 cutoff as around 35% or higher, though other people have used 15% or higher as a cutoff. And then for DCP, we tend to use 7.5 as a cutoff. So above 7.5 would carry a worse prognosis than below 7.5. Same for L3, over 15 or 35% would carry a worse prognosis than under those cutoffs.
Great. Thank you so much, Neil. In the interest of time, we'll do one more question. And so the next question was, what do you think in the future there will be a role for downstaging with the new systemic therapy, systemic therapies?
Yeah, so it's a great question. I do think so. I think a lot of centers, including our own, are thinking about how to combine local regional therapy with systemic therapy, especially because of the new systemic therapy, especially atezo-bev and nivo are so exciting, as we just heard about. So Marina and others, the way I would currently think about it is, or what we're proposing to do at our center is, if a patient is beyond Milan and they undergo local regional therapy and get downstage, we would list them. And if they have any recurrent or residual or untreated disease, we would likely refer them to GI oncology. And if they're Child-Pugh A, we'd likely try to put them on atezo-bev with additional local regional therapy as needed. And if they're Child-Pugh B or C, we'd likely put them on nivo. And same thing, we'd kind of with local regional therapy as needed. And so trying to really increase the chance that these downstaging patients can actually get to transplant and do well after transplant. So I do think there's a role. We have no data at all yet, but this is the plan to investigate this.
Great. Awesome. Well, thank you again so much, Neil. That was fantastic.